afternoon to all of us. It's 3 p.m. Ghana time, and we are welcome to today's presentation on rheumatoid arthritis. This will be led by Dr. Jenny Gablah, Dr. Domika Katiba, and I'll be your moderator for today. Like we always do, throughout the course of a presentation, if you have any comments, questions, kindly make use of the chat box so that at the end of it, we'll have a discussion around it. We hope to be able to finish this presentation 30 minutes to allow more time for us to have a discussion. So please make use of the chat box if you have any. Otherwise, at the end of it, then you would be allowed to unmute yourself and then you make your comments, questions, or suggestions. Dr. Jenny, if you are ready, kindly unmute and then go ahead with the presentation. Thank you. Dr. Jenny, you may need to unmute yourself. Your microphone is muted.
Hello.
Right. Yeah, hi, okay. We can hear you now.
So good afternoon. My name is Jane Gablah. I'm presenting on rheumatoid arthritis, moderated by Dr. Katiba. This will be the outline of the presentation. We'll look at the definition, epidemiology, the etiology, pathophysiology, clinical features, investigations, management. We'll have our differentials and then our references. So rheumatoid arthritis is a chronic systemic inflammatory disease whose hallmark feature is a persistent symmetric polyarthritis that affects the joints of the hands and the feet. And it's one of the most common chronic inflammatory conditions with both articular and extra-articular manifestations. It's a progressive disease which results in pain, stiffness, and swelling of joints and can lead to significant mobility and increased mortality. The annual incidence worldwide of rheumatoid arthritis is approximately 3 cases per 10,000 population, with a prevalence of about 1%. And this increases with age, peaking between the middle ages to about 50 to 70 years. It typically affects all populations, although it's more prevalent in certain groups such as the Native Americans and less prevalent in the Blacks. Between the years 1990 to 2017, rheumatoid arthritis was responsible for 3.4 million disability-adjusted life years globally, with up to 50% more deaths recorded in persons with rheumatoid arthritis as compared to the general population. In regards to sex, women are 3 times more affected, especially with the ages before menopause. However, after menopause, the sex differences diminishes. In the aged population, the prevalence increases to about 2%. So with the etiological risk factors, the cause of rheumatoid arthritis is not exactly known. However, the clinical features are thought to be as a result of an interplay between certain factors being genetic, hormonal, infectious factors, lifestyle modifications. So with regards to gender, like I said earlier, women before the age of menopause are affected 3 times more than men. However, this incidence becomes similar after menopause. There's also an increased incidence among first-degree relatives. Genetic factors account for about 50% of the risk of developing rheumatoid arthritis. And it's shown that there's a strong association between susceptible people to rheumatoid arthritis and certain HLA halotypes, especially HLA-DR4, which accounts for about 50 to 75% of cases of rheumatoid arthritis. Another halotype that is implicated is the HLA-DRB1 or HLA-DR1. Rheumatoid arthritis may also be triggered by infectious agents, particularly periodontal organisms implicated in periodontal diseases, and then oral pathogens, so also certain gastrointestinal organisms. It's also been found that certain viruses trigger the disease, viruses such as Epstein-Barr virus and then cytomegalovirus. With regards to lifestyle, cigarette smoking has been seen to have a very strong association with the development of rheumatoid arthritis, especially in persons with the HLA-DR4. And cigarette smoking is also associated with a poor prognosis and reduced responsiveness to the treatments, the medical treatments that are used in rheumatoid arthritis. Certain factors have also been implicated, although these are less commonly associated with rheumatoid arthritis, and this include the dietary factors. It's believed that red meat intake, vitamin D deficiency, and excessive coffee consumption could predispose the person to having rheumatoid arthritis. So with the pathophysiology, we'll look at this picture to talk about the pathophysiology. So in persons who are susceptible to having the rheumatoid arthritis, that's those with the susceptibility genes, the HLA-DR4, HLA-DR1. It's thought that when there's a trigger between an interaction between the environmental factors and the susceptibility genes, there's modification of the body's own antigen, such as the immunoglobulin G and then other proteins such as the vimentin and type 2 collagen. So this modification goes through a process called citrullation, where the arginine within these proteins are converted into citrulline. So due to the susceptibility genes, the immune system no longer recognizes the modified proteins as self-antigens. The antigens are therefore picked up by the antigen-presenting cells and carried to the lymph nodes, thus activating the CD4 T helper cells. The T helper cells also stimulate the B cells to proliferate and differentiate into plasma cells, which produce the auto antibodies that are seen in patients with rheumatoid arthritis, as the rheumatoid factor and the anti-citrullinated peptide antibodies. So these antibodies that are produced then fight against the self-antigens. The T helper cells and the antibodies then get to the joint through the circulation and secrete cytokines such as the interferon gamma and the interleukin 17 to increase macrophages, which then produce more cytokines such as the interleukin 6, tumor necrosis factor alpha, the interleukin 1. And this stimulates the synovial cells to proliferate and form what we call a panus. So the panus is basically a thick, swollen synovial membrane with granulation tissue made up of fibroblasts, inflammatory cells, myofibroblasts. So over time, the panus also damages the cartilage and other soft tissues and erodes the bone. The activated synovial cells also secrete proteases, which break down proteins in the articular cartilage. So the inflammatory cytokines that are produced also increase the proteins on the surface of the T cells, and these proteins are called rank L. And this causes the T cells to bind to rank, which is found on osteoclasts, causing osteoclasts to break down bone. So the auto antibodies also that are produced, the rheumatoid factor and the anti-citrullinated peptide antibodies also enter the joint space, with the rheumatoid factor targeting the Fc domain of the altered immunoglobulin G, while the anti-citrullinated peptide antibodies target the citrullinated proteins, that's the vimentin type 2 collagen. And these form immune complexes which accumulate in the synovial fluid and activate the complement system. Over time, chronic inflammation causes angiogenesis around the joints, allowing more inflammatory cells to arrive. And then as the disease progresses, multiple joints are inflamed and then gradually destroyed. And then the inflammatory cytokines spread through the blood, through the circulation to get to other parts of the body, causing the extra-articular manifestation. So basically, this is just a summary of pathophysiology. So this picture shows the changes in the joint space of patients with rheumatoid arthritis, where we have the inflammatory cells, the bone erosion, the inflamed tendons. So we move on to the clinical features. The clinical features can be divided into the early features and then the late features. With the early features, what we typically have are constitutional, non-specific symptoms. So we could have, the patient could present with fatigue, malaise, low-grade fever, weight loss, could have morning stiffness, and difficulty in performing certain activities. There could also be synovitis, mostly affecting the metacarpophalangeal joints and the proximal interphalangeal joints, and also the tendon sheets around the joints. With the late clinical features, this is where we see the Boutonniere's deformity and the swan neck deformity that are typically found in patients with rheumatoid arthritis. And the late features are mainly destructive features, and they are typically seen when in patients whose disease are not controlled or who are not on medications to control the disease. So with the Boutonniere's deformity, there's flexion of the proximal interphalangeal joint with hyperextension of the distal interphalangeal joints, while the swan neck deformity is the opposite of the Boutonniere. So with the swan neck deformity, we have hyperextension of the proximal interphalangeal joints and flexion of the distal interphalangeal joints. So like I said earlier, there could be extra articular manifestations of rheumatoid arthritis. And with the eyes, we could have keratoconjunctivitis, scleritis. With the lungs, we could have parenchymal lung disease. In patients who have pre-existing interstitial lung disease, we develop rheumatoid nodules. We have what we call the Kaplan syndrome. Then with the hearts, we could have the coronary artery disease, pericarditis. Another syndrome that we could have is the Felty syndrome, which is a triad of rheumatoid arthritis, splenomegaly, and neutropenia. So we'll move on to the investigations. So there's no one single test that can be done to say that a patient has rheumatoid arthritis. However, the diagnosis is made based on clinical, laboratory, and imaging features. So the laboratory features basically include the acute phase testing for the acute phase reactants, as the ESR and the C-reactive protein. And these are typically elevated in patients with rheumatoid arthritis. However, in certain patients, we could have them having normal levels of the ESR and the CRP. So that's if we have a patient with normal levels, there should be more prompting, more further studies into finding out whether it is actually rheumatoid arthritis or it could be other diseases that are presenting this way. And then the elevation in the ESR and the CRP levels point to an ongoing inflammatory process and can be used to determine disease severity. There's also the rheumatoid factor and then the anti-citrullinated peptide antibodies that are typically tested for. And these are the serological tests that are done. So with the rheumatoid factor, it is typically present in up to 75% of patients with rheumatoid arthritis. Although it is not specific and can be found in 5 to 10% of healthy patients and about 20 to 30% of patients with SLE and other differentials of rheumatoid arthritis. However, higher values of the rheumatoid factor, about 3 times the upper limit, suggests a great specificity for the rheumatoid arthritis. With the anti-citrullinated peptide antibody, it has a similar sensitivity to as the rheumatoid factor, but has a higher specificity for rheumatoid arthritis. The anti-mutated citrullinated vimentin, that's the anti-MCV-SC, also has similar results to the ACP. The anti-nuclear antibody assay, the ANA assay, is done typically to rule out other diagnoses. So a negative test would exclude other diagnoses such as the SLE. However, in certain patients, in about 1/3 of patients with rheumatoid arthritis, we could have the ANA being positive. That if it's positive and the diagnosis is not certain, the further tests such as the anti-double-stranded DNA and anti-Smith antibody tests should be done to rule out SLE. So radiographical investigations that can be done, typically the first choice is the X-rays. The X-rays which will show the bony erosions of the joints. However, other radiographical investigations such as the MRI and the ultrasound could be done. And these are usually done in patients who present with normal X-rays, but then have clinical features of the rheumatoid arthritis. So the MRI and the ultrasound are more sensitive to picking up ongoing synovitis compared to the X-rays. So this picture shows the radiological changes that are seen in the bones of patients with rheumatoid arthritis, whether we have the bone erosion with the bone displacement. So diagnosis of rheumatoid arthritis can be made when the following are all present: when there's inflammatory arthritis of 3 or more joints, when there's positive rheumatoid factor and/or the anti-citrullinated peptide antibodies, where there's elevated C-reactive protein or ESR, and where other diseases with similar clinical features have been excluded, and with a duration of symptoms of more than 6 weeks. And these factors are all consistent with the 2010 classification criteria for rheumatoid arthritis. And this is the criteria where we have, it includes parameters such as the joint involvement, serology, acute phase reactants, and then duration of symptoms. So each parameter has a particular score. So a score of greater than 6 classifies the patient as having rheumatoid arthritis. In certain patients, they might not meet the criteria, the 2010 ACR EU LER criteria. And these patients could be patients who are seronegative for the rheumatoid factor or the ACP, but may have symmetric polyarthritis, rheumatoid nodules, or erosions on X-rays. So they might have the serological test being negative, but however, a diagnosis of rheumatoid arthritis can be made in them if they have these features and other other diagnoses have been ruled out. Also, patients with recent onset rheumatoid arthritis with symptoms less than 6 weeks who presents with severe features suggestive of rheumatoid arthritis. The diagnosis of rheumatoid arthritis can be made in them if other causes of their symptoms have been ruled out. Same as with patients with inactive rheumatoid arthritis who present without active arthritis or without elevated acute phase reactants, where there's bone erosion or on X-ray and positive rheumatoid factor, and then the ACP, where we have ruled out alternative diagnosis. We can make a diagnosis of rheumatoid arthritis in this group of persons. So move on to the management. The goals of management include preventing or controlling joint damage, preventing loss of function, decreasing the pain and inflammation the patient has, maintaining quality of life, and avoiding or minimizing adverse effects of the medication. So management typically is a multidisciplinary approach and includes pharmacological, non-pharmacological, surgical interventions. So I want to say that when a patient is diagnosed with rheumatoid arthritis, there's a need for a rheumatologist to be involved in the treatment of the patient. So with a non-pharmacological approach, it includes exercise, diet, lifestyle modification, counseling, stress reduction. Counseling is important because the patient has to understand their disease. The patient has to decide on the patient helps in choosing their medication, the mode of delivery of their medications. Also, regards to the patient, if the patient, for example, wants to get pregnant, the patient needs to understand that these medications could have effects on their pregnancy, and they need to hold on for a while. So counseling is important in their management. With the pharmacological management, it employs 3 main medications, classes of medications. The disease-modifying anti-rheumatic drugs, that's the DMARDs, where we have the biologics, the non-biologics, and the targeted synthetics. So the non-biologics basically target the entire immune system, while the biologics and the targeted synthetics target certain pathways of the inflammatory process. Then we have the NSAIDs also, and the corticosteroids. So prior to starting or resuming or increasing the dose of therapy that is given, there are certain tests that should be done. So general testing for all patients include a baseline full blood count, a BU creatinine, an LFT, an ESRN, the C-reactive protein. So I said earlier that the ESRN C-reactive protein values show the degree of the severity of the disease. So we need to know a baseline for them. And then in their follow-ups, we repeat to see whether they are improving on medication. Also, some of the medications that are used are hepatotoxic, and then also toxic to the renal system. Some also end up causing anemia and thrombocytosis. In patients receiving the interleukin-6 inhibitors and the JAK inhibitors, that's the targeted synthetics, the lipids are also monitored. So most of the medications that are used are suppressing the immune system. That is necessary for us to screen for hepatitis B and C, and then latent tuberculosis, in order to prevent an infection when there's a start of the treatment. So if we test for the hep B, hep C, and then TB, and then the patient is positive for this, we have to treat it before we start our therapy. For patients on hydroxychloroquine use, that's a non-biologic DMAT, it's necessary to do an ophthalmologic screening for them, as it could be destructive. The medication could be destructive to the retina. So pre-treatment interventions include reducing the risk of cardiovascular disease, so lifestyle modification, cessation of smoking. Because I said earlier that smoking has a poor prognostic factor to the disease, and also reduces sensitivity to the medication. Immunization also against certain viral diseases. So in a patient with active rheumatoid arthritis, the first line of choice of medication is the DMARDs, the non-biologics specifically. So the methotrexate, that's the first line medication that is used in patients with active rheumatoid arthritis. However, in patients who are unable to take the methotrexate, they may require an alternate agent, such as the other types of the non-biologics, which are the hydroxychloroquine, the sulfasalazine, or the flavonoid. And these are used together with NSAIDs or glucocorticoids, and these are adjunct therapy. In patients who are resistant to the initial DMAT therapy, so in patients where we start the methotrexate but it's not working for them, we usually treat them with a combination of DMATs. So we add other DMATs to the methotrexate. So we could have a methotrexate plus the sulfasalazine or hydroxychloroquine, or a methotrexate plus a TNF inhibitor, that's a biologic, such as the infliximab. In patients resistant to initial or subsequent combination therapy or subsequent treatment that includes a biologic or targeted synthetic DMAT, we switch to an alternate biologic or targeted synthetic DMAT altogether. So assessment and monitoring of patients. So once we start patients on treatment, it's required that we do a regular follow-up and assessment. And with the follow-up, it involves us repeating the CRP and ESR, repeating their liver function test, sorry, and their renal function test. With the imaging, it's not routinely repeated every follow-up. It's just we just need a baseline to see the radiological changes that the patient has developed. So surgical interventions include a synovectomy, tendon realignment, reconstructive surgery or arthroplasty, and arthrodesis. So prognosis of the disease. In patients, it has been seen that in patients who are managed with a DMAT and with a multidisciplinary approach, they have significantly improved outcomes. However, certain factors are associated with poor disease outcomes, including bone erosions that are seen radiographically, a positive rheumatoid factor, or the presence of the anticyclic citrinated peptide, where there's extra articular involvement, and then functional limitation. Other factors that worsen the prognosis include cigarette smoking, lower socioeconomic status, as they are unable to continue on their medication, the female sex, and with the older population. So some of the differentials we could have are SLE, which is quite difficult to differentiate from rheumatoid arthritis. However, with the presence of other symptoms of the SLE, such as the mother rash, we could make the diagnosis, and then the ANA, a positive ANA with a positive antihistamine and anti-double-stranded DNA, we could make a diagnosis of SLE. Also with the osteoarthritis, they would have the presence of the Heberden's nodes. Also, typically, they would have the DIP, the distal interphalangeal joints being involved. And also with their stiffness, it's more commonly occurs in the evenings and lasts for shorter periods, unlike the rheumatoid arthritis, which occurs usually in the mornings after periods of rest. With this psoriatic arthritis, this is also difficult to distinguish from rheumatoid arthritis. And so the diagnosis of psoriatic arthritis is typically made in patients who present with the symmetric polyarthritis who are seronegative for the rheumatoid factor and the anti-cyclic peptide, anti-citrullinated peptide antibodies, who also have psoriasis. So psoriatic arthritis is then made in this patient. The diagnosis of psoriatic arthritis is then made in this patient. Okay, so these are my references. Thank you.
Great. Thank you very much, Dr. Jenny, for an excellent job done. I'll be able to do this in about 30 minutes. So the floor is open for questions. If you have such, you could kindly electronically raise up your hand, and then I would unmute you to talk. As well, if you want to put your questions in the chat box, you could make use of that. Meanwhile, I'm just putting up a link to a short survey that takes about a minute so that we get to assess the presentation that we have done this afternoon, and also for us to be able to improve upon our presentations. So just take a minute of your time to click on the link that I'm putting in the chat box. Yeah, so it's up there. Just click on the link. It takes you to an evaluation survey of this presentation, which takes just about a minute of your time. And then we get to have your responses to improve upon further or subsequent presentations. I see we have a hand up from Deborah Mensah. Deborah, please go ahead with, unmute yourself and then go ahead with your comment or question or suggestion.
Hello.
Hi.
Yes, thank you very much, Dr. Jenny, for the presentation. I think it was a good one. I wanted to ask concerning the management of the rheumatoid arthritis. You mentioned that because of the steroid use, you have to screen for Hep B, Hep C, and then treat them before you start the medications. But I want to know, since these ones are chronic diseases and then you manage them, at what point do you say, or what are the indications, the markers that tell you that this patient can start taking the medications? Thank you.
Great. Thank you very much, Debbie, for the comment, the question. Jenny, do you have a response to her? Dr. Jenny,
So
can you hear me? Yeah, all right, go ahead.
So the Hep C can be treated with a Hep B. So we want the core antibodies. We want to clear the core antibodies and then also the surface antigens. So after we've treated the person for the required duration, we need to treat the patients of the Hep B. Then repeat the Hep B surface antigen and the core antibodies to see if we've eliminated them.
Yeah, great. So typically, I'm happy that that has come up because, you know, we are endemic for viral hepatitis B. And so like at the rheumatology clinic in Kolebu, what we used to do with Dr. Day and Dr. Misata was that if you have, for all the patients that they were going to start on the steroid or even the DMAPs, typically what they will ask you to do is to do the hepatitis B profile. So they will not even go for just the hepatitis B surface antigen, because obviously diagnosis of chronic hepatitis requires the core antibody of the IgG type, which is usually picked in the profile. More so, there are some people who have lost their surface antigen as well. So usually they would ask you to do the profile. And if the core antibody of the IgG is positive, they'll go ahead to treat you. They put you on tenofovir for the treatment of the hepatitis B, as long as you are on the immunosuppressant therapy, because like generally said, usually we treat hepatitis B to achieve a sustained virological response. For the hepatitis C, obviously there is a cure for hepatitis C. And so once you test and the antibody is positive, usually what they ask you to do is to do either the PCR or you do the antigen. And then you are started on the cure for hepatitis C. There's of course based combinations. And whilst you are continuing on your immunosuppressant therapy, pending the duration of the treatment, following that, then they go ahead to either check the viral load, confirm that this has been cleared off from your system, as it's an RNA virus. So for the full duration of treatment, or for as long as you are on the immunosuppressant therapy, typically for Hep B, they'll continue on the tenofovir. For the Hep C, obviously that usually looks at a finite duration, depending on when we're able to clear the viral load, and then the 12 weeks post treatment, usually the viral load is done to demonstrate a cure for hepatitis C. So these are usually the technical details. I dare to say that usually when you make a diagnosis of rheumatoid arthritis, best is, like she rightly said, the multidisciplinary team approach. There's a need for the rheumatologists, because obviously each of the specialists have their technical field. So when I see such cases, typically, ideally, at least you should have a visit to the rheumatologist. Unfortunately, nationwide, all of Ghana will just have 2 of them. So, and both are in Kolego Hospital. So it will mean that all these people have to get in there to have like an expert kind of guidance. But typically what is done is, if you meet them usually for 1 or 2 sessions, they would refer you back to your primary caregiver with guidance on what to do, and with a linkage of care if there's a need to. So I'm happy that you brought that up. And those are the technical explanations regards the testing, what is done for B and what is done for C, and the treatment, what is done for B and what is done for C, as long as you are going to be on immunosuppressant therapy. So welcome any more questions or suggestions. I don't see any hand up. In the chat box as well, I do not see any comments in there. Just a quick reminder again that we wish to evaluate today's presentation with the quick survey. It takes just a minute of your time. Kindly click on the link that is in the chat box, and then you'll be able to provide us with your responses. If you have any question, kindly electronically raise up your hand. I would unmute you to go ahead with your question, comment, suggestion, or whatsoever. I see today we are privileged to be joined by Dr. Kelly Hartfield. Kelly Hartfield is the founder of Ghana Medical Help, on whose platform we using for this educational webinars and for all our in-person teachings as well. So we are grateful to Ghana Medical Help for helping us with continuous medical education in the rural area. Kelly, thanks for the good job. Dr. Jenny, I guess you did an excellent work. So I don't seem to, you've covered all the parts actually on my list. So I'm not surprised that nobody is asking any further questions. The little I just want to add in is that, like you would have noticed, the criteria you used for the diagnosis and what is currently used is the 2010 ACR EULA criteria, American College American College of Rheumatology and the European League Against Rheumatism. So that's the current one that we use. There is an old criteria referred to as the 1987 criteria, obviously before most people on this platform were born. The emphasis on that one was about the bone changes. And so what the new criteria seek to do is to be able to pick up RA early rather than waiting for the deforming changes. And once the reasoning is that once those the changes are there, really you cannot do any much. Joint deformities, contractures, whatever you would have heard about RA, ulnar nerve deviation, Z, deformities, all of that. That's what the 1987 criteria was based on. And now we have moved away from that to looking at picking up the symptoms using the clinical bit, which is actually extremely important and actually the hallmark of rheumatoid arthritis. History, and your physical examination. Then adding into the serological bit and then the acute phase reactants and the duration of the symptoms. So these are things that we should be aware of and not wait to have the deformities. Again, I'm sure we've already tackled the part regards the Hep B and Hep C, which is quite something that we need to highlight on because in our environment, those are very common issues. Maybe you may not have that in the developed world. So when a presentation like this is done elsewhere, you realize they may not emphasize on testing you for a B and C, but our domain may be a bit different. Again, I can't overemphasize the need for thorough history taken with rheumatoid arthritis. Like you see, there's what is called seronegative arthritis. There's what is called early RA. All these are based on your clinical findings because seronegative arthritis simply means that the various, what do you call them? Serological tests are negative. And so that is a part of it. Also, the treatment, I realize she's brought all of that, but we still need to emphasize the fact about the multidisciplinary team approach to it, involving physiotherapists, involving occupational therapists, involving clinical psychologists, because it's a lifelong disease. So again, that is an emphasis of this presentation. But I would agree that you did an excellent work, and I'm sure we learned a thing or two about rheumatoid arthritis. Thanks for a great job done. And let me just quickly check again the chat box to see if there are any. Okay, so we have no questions and there are no hands up. Just to say thank you to all of you for joining us for today's presentation. It has been good, it has been concise, it has been excellent. Thank you for joining us. Hopefully next week we would come your way with another topic. Kindly check on the various platforms as well. Please remember to give us your evaluation by clicking on the link I've put up in the chat box. Thank you very much and God bless us all. Bye-bye.